Kia ora koutou. Thank you so much for inviting me to give this talk. A huge thanks to MECFS Canterbury for this opportunity. I'm Mona Jeffries. I'm an associate professor at Te Herenga Waka, Victoria University of Wellington, with a real interest in long COVID. I'm hesitant to say mostly, but probably mostly because I live with MECFS. And when at the beginning of the pandemic, realized really quite early on the parallels. We watched what was happening in Europe, watched what was happening in North America, and realized that it was only a matter of time before it happened here in Aotearoa. So we did a number of different studies, which I'm going to talk about, and the one I'm going to spend most time on was a study which is just coming to an end, funded by the Health Research Council of New Zealand, and it was a very large collaborative study, as I'll talk to you about. The main study I'm going to talk to you about was co-designing a primary healthcare resource for adults with long COVID. I'm very aware that some of you watching this will have MECFS and not long COVID, and I do hope that some of what I present is going to feel of relevance to you as well. And also very clear this is about adults, and again, some of it might be of use to parents of children with long COVID, but all the participants that we had in the study were adults. A lot of my slides, you'll see some of this beautiful artwork, which was created by people with long COVID as part of the research. And I'll explain some of the pictures to you and the meanings behind them, but it was a really key part of the methods that we used. Sorry. So the background to the study, when we first began this, we were saying that somewhere between 4 and 14% of people who had a COVID-19 infection developed long COVID. And as you'll know, then very recently, so just last month, then the Ministry of Health released results from New Zealand, which were the first results that we've got, showing that our estimates were broadly speaking right, so somewhere down around the kind of lower end of that estimate. But very consistent with what's being seen overseas. Obviously, sorry, not obviously, but long COVID has changed over the history of COVID-19. It was much more common in the very early strains of the illness. And it is also being vaccinated is a protective factor against getting long COVID. So not just against getting COVID-19, but against getting long COVID as well. So therefore, when COVID-19 arrived in Aotearoa, we were already reasonably protected. And so it's not surprising that our estimates of how common it is are at the lower end of that international best guess. It is a complicated condition, and actually it's probably a number of different conditions. It can affect many systems of the body. In any one person can affect a number of systems and can present very differently for different people. And what makes it really quite difficult from a health professional point of view is this fluctuating nature of the symptoms. So on a day that you see me, I might seem reasonably well, and often that's how people might present to a health professional, because on the days their symptoms are particularly bad, they might well not be able to get to an appointment. So understanding these symptoms can be really challenging for a health professional, and obviously a huge challenge for individuals with the symptoms themselves. These symptoms can range from very mild, so it might be just a persistent cough, to really severe, so it can severely limit activities of daily living. There were a number of efforts to set up long COVID clinics across the country. The one in Canterbury didn't last very well, although I've heard rumours that there may be some efforts to bring that back to life again. The one in Auckland never took off at Waitemata DHB, and so the only one that we're aware of continuing is the service provided at Taranaki through Taranaki Base Hospital, which is an allied-led health allied-led service, and is it's but they do have doctors involved as well. So we first began our sort of interest in the impact of COVID-19 through a study that was funded by the Ministry of Health called Nakawekawe o Mate Corona, the impact of COVID-19 in Aotearoa. This wasn't only about long COVID, it was about lots of impacts of having COVID-19, about social, financial, as well as health impacts. It was a one-year study. Initially, it was meant to be a longitudinal study, so we were meant to be following people through time. When we first got the contract with the Ministry of Health, there were 2,500 people in the entire country who had had COVID-19, so it seemed fully feasible to do that. By the time we began the study, we actually began on the day that we went into the second lockdown. We included, there were 8,500 people who were eligible for inclusion at that point. Even though it wasn't only about long COVID, we had a significant interest in long COVID. And so there was, we conducted a survey, and about 900 people took part, and we also did in-depth interviews with about, I think 62 people. From that piece of research, then it was very clear that people with long COVID, many of them had faced medical dismissal. Symptoms were often being framed as psychological, and individuals themselves didn't really know what was going on. So we heard many stories of people saying things like, it's probably just my asthma, or it's just that I'm getting older, or it's probably just because I'm fat and lazy. Those words having come from a health professional. So those combined to result in a delayed diagnosis, really fragmented and confusing care pathways, and it's perhaps even a bit too generous to say care pathways because there actually is no care pathway for long COVID. And what was really worrying was this need to self-advocate when people had got very limited energy. So that was the background that led us to think that we wanted to do something more and do something different. So the aim of the part of the study that I'm going to describe to you now was to co-design an evidence-based resource to support the care and the support of people with long COVID. There were two very clear aspects to how we wanted to run this study. One was making sure that we adhered to a Te Tiriti o Waitangi relationship framework, and the other was to make sure that we authentically used co-design methodology. And I'll come on to talk about what those mean in the next slides. This Te Tiriti relationship framework was something which was developed by Whaia Iris Pahau, who has actually been an integral part of all of our studies all the way through. She has guided all of our research and has chaired the Ropu Kaitiaki, the advisory board, which has guided the research, both the original Ministry of Health study and this current one. So the work was co-led by myself and Associate Professor Lynn Russell, who is a senior Māori researcher at Herenga Waka, Victoria University of Wellington. And we were very clear that this was about shared leadership and equal resourcing. So when we were asking for money to do this piece of research, we were very clear that we made sure that both the Māori team and the non-Māori team had got sufficient resource to do what they wanted to do in a way that they needed to do it. And that didn't mean that we split it down the middle and had half each. It meant that we tried to understand that the way that the Māori team might want to work might be different to how the non-Māori team might want to work, and that each of those were equally resourced. For example, then for the Māori team, it was really important that they conducted all of their workshops face-to-face, which meant more travel than the non-Māori team, who were really keen to make sure that we had some options for online workshops so that we could include people who were scattered or potentially lived more rurally. So all that was factored into the resourcing. We had collective decision-making, so it wasn't that we voted and said who's winning. It was very clear that we discussed everything and we tried to work it out in a collegial kind of way. We wanted to make sure that the whole ethos of the study reflected a two-world view. That meant that every strategy that we considered in terms of recruitment, in terms of analysis, in terms of dissemination was discussed, that appropriate tikanga were adhered to, that all of our policies and procedures were done in the right way. And it's actually turned out to be a really important way of working for us and something that we're going to be able to continue into the future. The second underpinning methodology was that of co-design, and the specific methodology that we chose to use was based on the Stanford model of design-led thinking. This is a 5-stage process, and as we go through design, as I go through talking about the methods of the study, then I'll be able to pick out which stage we were at. But the kind of key points are that patients and researchers are equal partners. So the evidence that comes out from this type of research may be slightly different to what some people might consider to be the evidence. There's a Western scientific way of considering evidence, but that is only one way. And so we were really important, for us, it was really important to listen to what people with lived experience of long COVID wanted, what mattered to them, and make sure that that was valued equally. We wanted to make sure that lived experience shaped the content of what we did. So before we even began the study, we had a number of people with long COVID on our group as researchers, and they were engaged with throughout the process, as well as those people who were research participants. And the idea of doing this is that what we produce at the end, so the tools that we produce, meet the needs not only of the health system and health professionals, but also of patients. And I made that point and said that in exactly that way, because very often the health system is not designed with the needs of patients in mind. So for us, it was really important that we were balancing these two things. So as an overview, then we had 2 sets of workshops. We had what we call our phase 1 workshop, and this reflects the phase 1 of this Stanford model, the empathize model. But it was an awful lot more than empathizing. It was listening to what people had experienced, to what they want, to what worked well and what hadn't worked, to what support people had received and what they hadn't received, where the gaps were. We used art as a medium for expressing and sharing. There has been concern raised with us since that people who came to these workshops might only be the people who were arty. We didn't actually tell people before they came that this is what they would be doing. So I think that probably is not the case, and people who didn't want to create anything didn't have to, of course. The workshops were audio recorded, transcribed, and then analysed thematically, which is an approach that we use very often in qualitative research, where we're talking to people and trying to explore ideas. The research team then went away and looked at all this data, so the recordings, the information that came out of them, and we used those to go through the next 2 stages of the model. So that was the define stage, defining what seemed to be the big issues, the gaps in care, and ideate. So we came up with some ideas of solutions that we thought might address some of these gaps. We then took these into the phase 2 workshops and worked with a smaller group of people with long COVID iteratively over time, so the same group. So they were chosen from the original group, and we worked with them through a number of different workshops, trying to refine and improve on this prototype, so that by the end we felt like we had something that probably worked. And we then went to the testing stage, and we've only managed to test this with a small number of health professionals so far, but we're hoping that it would be lovely to try to test it a bit further. So in those first phase of workshops, then we had 54 people. There were 13 workshops that were done. So there was the Tāngata Whenua, there were 14 Māori participants who took part, and then we had 41 non-Māori participants, of whom 11 were Pacific. So Tāngata Tiriti being everyone who's non-Māori. Those workshops, as I said, mostly were face-to-face, but there were a number done online so that people could take part remotely, so from people who lived rurally could more easily take part. Everyone was invited to bring a support person if they wanted to. A number of people did, but in general, people didn't. So we ran a specific workshop for support people, because we felt that they may have perceptions and views to offer that perhaps couldn't be shared in front of the person with long COVID. Interestingly, actually, nothing new came up. All we heard from those support people was exactly what we'd already heard from the people with lived experience themselves. Most of our participants were female, which is not surprising given what we know about long COVID. And most were in most of middle age, sort of between 45 and 64, with a number of young adults as well, and a few younger and older people. So I probably should have explained a bit more what we did at these workshops. We gave people these art craft materials, and we said to them, just describe to us what you've experienced. This person described their life as a teardrop. And how they described it to us, this is directly from the recording that was made as they were, after they had created it, presented it back to the group. This is supposed to resemble a teardrop. That's how I feel, that I could just cry all the time. Around it are all the words that have been taken away from me, like independence, support, job, friends, GP, normal company, hospital, help, acknowledgement, compassion, activities, empathy, socializing, basic needs. The middle is me with a smiley face, hoping one day my life is going to turn back around again. This person described to us just what it felt like to be met with dismissal and criticism. All those dots around the outside. So sorry, I should say she created this this house in the middle, which depicts Te Whare Tapawha, the Māori model of health. And all the dots around the outside are the things I've tried. So you can see they're named things like exercise physiologist, cardiologist, occupational therapist, ME nurse, breathing physio, lifestyle doc, psychologist, counsellor, GP, health coach, HIP. They're all the things I've tried. Then when you're at the appointment, having people recommend things you should be doing or could be doing, that kind of became exhausting in itself. An occupational therapist I saw said I had to write what I was doing every 30 minutes, then rate how I was feeling and my fatigue rating scale. Filling in the form was fatiguing enough for me. I had to do that for a whole week. I thought particularly the occupational therapists and the health improvement practitioner at my GP were not helpful at all. They were very dismissive and criticizing of me. So it was these kinds of stories that reiterated to us just how important it was to try to make sure that we created something that could be used to help conversations between people with long COVID and their health professionals. This person highlighted the absence of a long COVID clinic. On the outside, I've sort of drawn what's left after the bomb went off. So their way of describing having long COVID was like a bomb. I've drawn that I'm usually at home, usually in bed or on the couch. I've put health and I've put a cross through that, and I've put unknown. I've put long COVID clinic with a cross through because I was part of that, but of course now it is no longer. And that was a theme that came out to us a number of times. And indeed, one of our participants had actually been to a long COVID clinic in Australia and came back and told the group just how wonderful it was having this sort of one-stop shop. Of course, it didn't make her better. We know there is no magic solution, but equally, then we know there are strategies and support mechanisms that can help, depending on how people's long COVID is playing out, depending on the symptoms. And to have people there, a whole range of health professionals, so a multidisciplinary clinic for her was particularly helpful. So from those 41 people, we gathered all that information and came up with kind of the key themes that were emerging from what people were saying. Things they really wanted their health professionals to know, and the gaps that they felt people didn't necessarily know, health professionals didn't necessarily know. The most important was that long COVID must be recognized as a physical condition. Now, knowing who I'm speaking to, then that barely needs saying, but there were a number, or many, I should say, many examples of people being dismissed, people being told it was all in their head, people being told they were being lazy and didn't want to go back to work, that sort of thing. So it's really important that health professionals take this on board and recognize that it is a physical condition with underlying pathophysiology that admittedly we don't fully understand, but we have some really good clues about what might be going on. People wanted an acknowledgement that long COVID affects all parts of their lives. So it's not just coming in and saying, this is my symptom, I want something, let's do something about it. It really requires a holistic approach, and it's not just about an individual. It's also about their partner and their whānau. Given that it is very often women who are getting long COVID and the age at which they are getting it, then many people have got dependents living at home. Many people are working, and not being able to look after dependents, not being able to work, has got a huge impact on other people living in the household or other whānau. There were barriers that people described to accessing care and support, and they weren't just physical, although physical barriers were important because of people not being able to get to appointments. There were financial barriers. Now, there's been an estimate that people with long COVID go to their GP about 4 times as often as people who don't have long COVID but of the same age and gender. Now, if you think going to the GP might cost you $60 or $70, it's the average rate of going to a GP is about 3 times a year. If somebody's going 12 times a year, that is a huge financial burden. There's a huge cognitive barrier to being able to go to a GP. You go in knowing that you've got your 15 minutes, you've got to say in that time what's wrong. You might only be allowed to talk about 1 or 2 symptoms. And when you're doing that, combined with cognitive dysfunction, that can be really difficult. There is a big emotional barrier to accessing care, and that very much is coming from people's experiences of negative experiences of not being believed and not being believed that there's something physically wrong with them. A lot of people talked about the harm related to graded exercise therapy, particularly if they were suffering from PEM or post-exertional malaise. This, particularly from what we heard, seemed to be coming from the health improvement practitioners who may not have a full understanding of the harm that can come from people pushing through PEM or pushing through with exercise and then having a resulting crash. A lot of people knew about pacing, but very few people had actually received any information about how you realistically might do that in a real kind of life. It's very easy to say, well, pace yourself. But the reality is that people's lives are still continuing. And so to actually understand how you can incorporate pacing into your day-to-day life was something people wanted us to be able to highlight. And almost everybody we spoke to felt that they spent far too much of their energy having to do their own research to present to their doctor and to self-advocate for the care that they should be being offered to them rather than them having to push for it. So that's the information that we took away, and as a team worked together to try to come up with some ideas of prototypes. The ones on the screen here came from the information from the 2 Pacific workshops, and this work was led by Professor Riz Firestone at Massey University in Wellington. So the prototypes that they came up with were the idea of having ambassadors and integrated within church health services. The idea of having some kind of wellness at home kit, so certainly something about improving information, but also some ideas of things that you can do at home. Peer support was something that was very important. So wanting to have other Pacific people who were able to understand and offer support, who knew what people were going through. And a very clear idea that information was not being given in a way that was accessible. And so some kind of visual storybook might be helpful. Over on the right-hand side, again, the idea of peer navigators in the community, so people being able to come along to appointments with you. So really the advocacy role that a number of support agencies currently fill, but coming from within the Pacific community. The idea of a mobile support app had a huge amount of interest, particularly for people who were housebound and unable to go to appointments. But obviously the cost of being able to access information, the cost of broadband costs was a barrier. And so the idea of something that might be accessible either at a low cost or no cost plan was something they wanted. The importance of culture and that coming through in terms of well-being and a broad understanding of what well-being means within a Pacific culture was very important. And the idea that actually this isn't just about physical health. This is, for many people, affecting their ability to work. And the idea of this, of having some kind of inclusive support, sort of wraparound support that might include looking for potentially jobs that that you might be able to do with certain limitations. Then there were a number of prototypes that came from the non-Māori, non-Pacific group. So the first one up there on the left, I know that you probably can't see the detail of this idea of a long COVID management pathway, but this was taken from some work that had been done in the States. And I think people really liked the idea of this, that some kind of map so that people knew where to go and what to expect. It was very clear that it wasn't acceptable to just take what was happening in the States and assume it would work well here, so that there needed to be some refining of that. For prototype 2, then there was some interest in looking at the post-COVID symptom map, which some of you may have come across before. This was developed by Fi Dunford and her team at Taranaki DHB, and it looks like the sort of spiderweb diagram highlights there it allows you to highlight the most pressing symptoms and functional limitations over time. So that if you use this over time, then it gives you a bit of a pattern of how those symptoms, which fluctuate, are changing and might facilitate communication better with a health professional. There was an idea that this potentially could be developed as an app. That hasn't yet happened, but I think that idea is still possibly floating around. There was a very clear idea that what people wanted was a one-stop shop, and that the most appropriate way for this to be would be a virtual setup. Something where GPs could potentially refer in, there could be different sorts of support available, and if there was a need for face-to-face assessment, that then could be there could be a referral out to specialists. The importance of it being virtual was to try to improve access and to potentially reduce the amount of energy that might be required. Again, this is not where we ended up going. It's not at all because we don't believe that that's a really good idea, but the reality is that in the constraints of the health system, and we've had conversations with the Ministry of Health who are entirely clear that there is no money going to be put into long COVID care, that we needed to come up with something which could sit within the existing structure of the health system and didn't have an additional cost. So we took all these ideas to our phase 2 workshops. So we presented them, as I said, to participants who had been part of phase 1, and they were the same participants over time. These workshops were spaced about 6 weeks apart, so that gave us time between workshops to take on board people's considerations, to make changes, and then present back where we had got to and get more feedback. The second last workshop that we held was with health professionals, because we wanted to make sure that, as I said at the beginning, that what we produced was of use to the health system. So these were health professionals working in the primary healthcare space. And then we had a final workshop where we got the final sign-off from our research partners, so the people with lived experience. While we were doing all that, we had a team of people at the university conducting a scoping review of the literature to make sure that what we were suggesting and presenting was informed by the latest evidence. The evidence is changing really fast, so even what we present now is probably not the latest evidence because we're a month or two behind. And this is a problem for what our final prototype is. And as I was chatting to Rose at the beginning and saying that we are going to have to try to keep this up to date, because it's really important that we don't think this is a static document which can't be improved upon. So we produced something which was a bit of a mess at the beginning, and we soon realized we needed someone younger on our team to improve our graphic design. But the basic idea was that we wanted to look across a pathway. We didn't want this to be linear, hence the double-headed yellow arrows between diagnosis, early assessment, ongoing management, and supportive care. We wanted to make sure that this was simple, kept to one page, but that the evidence sitting behind it was clear. So each of the boxes was a hyperlink that led to some kind of online evidence. You'll be glad to know that is not the final version of what we came up with. It improves. But that was what we took to our participants and said, how can we improve it? So what did people with long COVID want? They wanted us to be really explicit that long COVID is a physical condition. They wanted emphasis on pacing, on validation, and partnership between people with long COVID and their health professionals. They wanted a very clear statement that mental distress is a consequence and not a cause of long COVID, and warnings against graded exercise therapy for people who experience PEM. They wanted a statement that there is no evidence that brain retraining can treat a physical condition, and that very much is coming as a trying to battle against the push from a number of primary care professionals who are trying to suggest that, for example, the lightning process or the switch is something that can cure you of long COVID. They wanted to emphasize the overlap with MECFS, but to also make clear that there are some people for whom the symptoms of long COVID do not reflect MECFS, and this is a separate condition. By the time we got to the health professional workshop, we'd implemented all those changes. So what they suggested to us was that they wanted some further guidance on red flags. People wanted to know what to do if somebody presented with symptoms that were worrisome. They wanted a very clear integration with the New Zealand referral pathways, and that's something which we're working on. So our ideal would be to get this single document uploaded into health pathways, and we're hoping that that may happen in the future. They reiterated the importance of keeping up to date with the emerging evidence, and they wanted to improve some of the links that we had. So they felt that some of the ones we had were not particularly useful or clear. So this is the final version of what we came up with. Instead of the boxes, we've ended up underlining where the hyperlinks are. The version that I'm showing on the screen now doesn't allow me to click through them, but I'll give you the link where you can find this resource that has the live hyperlinks. We moved that purple bit at the bottom, the evidence-based therapies and further reading, out of what we saw as a pathway for people with long COVID, and emphasise that actually those double-headed arrows really only applied to the ongoing management and supportive care. That diagnosis needs to be quite clear, and early management should be that green box. It should be something on its own. I think you can see there we kind of included a lot of what people wanted. So things around, for example, pacing, the importance of evidence. There was definitely an interest in having information given to participants, or sorry, given to people with long COVID about what supportive care they were potentially eligible for, things around respite and care for whānau and carers as well. There is one link up at the top here that people with long COVID want a whānau order holistic approach to management. And although this came from the Māori team, then that actually came through from virtually everybody, that people wanted to their health professionals to consider them as an individual, not as a set of symptoms to be treated. And the resource that came from the Māori team was this Wheke model, so a Wheke being an octopus. And although this came from Māori participants, and you can see that they're almost identical to the thoughts that came through from the non-Māori participants. So wanting to have an integrated Hauora approach, a service that integrates traditional and alternative healing practices with conventional medical care. Over on the right-hand side, steering the journey, a dedicated service with health-trained navigators to help us journey through the system. Down in the bottom left, support the supporters, services to support those who care for us, counselling and mental health support groups, and family counselling. And in blue over on the right, raising the profile, they felt there really was not the awareness, particularly among Māori communities, but probably that extends much more widely, wanting some education for communities, support groups, and although there are a number of support groups and not as many Māori as we might expect access those, and so they wanted further support groups and educational resources. The bits in purple, which I haven't read out, are probably a bit more general problems with the health system not meeting the needs of Māori. And I've included this here because I think it's really important to remember that there was is a very, very important Māori academic, Mason Jury, Tā Mason, Sir Mason, who has always said what is good for Māori is good for everybody. I don't think there is anything on this slide that people would say, that's for Māori, not for me. I think people want to have this idea of a whānau ora approach and to be considered as holistic individuals, not just symptoms. So I'm going to stop there. Huge thanks go to all our participants. The people who took part gave large amounts of energy, and I know at a significant cost to themselves, to take part in this research, to be research partners with us. We had a very large research team, I would also like to extend my thanks, and it was funded by the Health Research Council of New Zealand. And there on the slide is the URL, which I know is very long. I've struggled to try to make it into one of those tiny URLs, although I'd like to. But you can follow that link and it will take you to the resource where all the hyperlinks are live and available. Thank you. Question here from Simon.
Yeah.
So other than graded exercise therapy, does the model filter out other ineffective treatment plans? Not specifically, other than that clear statement about brain retraining. What we're hoping to do is to achieve that by keeping our links up to date. So down the bottom in that purple box, then it's a bit easier for us to keep that up to date than it is to update some of the other hyperlinks. So that specifically a lot of them just go to pages that we're keeping on our university web page where we can much more quickly update those. So no, we haven't specifically filtered other stuff out, but we are aiming as the research evolves to try to keep that as up to date as possible.
Yeah, that's really helpful because I think there's a bell curve of other treatments that GPs and others are recommending that maybe cause more harm than good.
Yeah, I mean, it's really tricky though, isn't it? Because I think, for some people, then some things do benefit them. And the evidence is really, it's emerging, but it's not fully clear cut. So if we look at something which has been around for a long time, then the ways that we would assess evidence rely on decades of studies having been done. So I think we're having to kind of change our approach to what is evidence, which makes it really difficult to do, but I still feel like we need to do this, to say, well, yes, there's good evidence for some things, like, for example, for treating symptoms of dysautonomia. For other things, we think there's good evidence, and so I think we need to be a bit more accept a bit more uncertainty in our evidence. For some things seem to work, like, for example, LDN, low dose naltrexone, seems to work for about half of people who try it. And that's really difficult because we have no idea yet why it works for some people and not for others. So it's a drug which at a higher dose is used for opioid overdoses, but at a low dose has been talked about in the ME community for quite a long time. But I think it's only fairly recently, but Rose, do correct me if I'm wrong in this, that there have been studies where people have been looking at it for treating symptoms.
There is a little bit of evidence. We have a handout on our website about it as well, with some research. Yeah.
So it seems to be, but we still don't know why it works for some people and not others. And that's a real problem for health professionals because you don't want to just be trying stuff that
Yeah.
may work or may not. Almost certainly will give you side effects because most things do. So yeah, it's a real juggle.
My wife is a health economist who models funding models, etc. So that's why I asked my second question,
Mm.
whether it's your model is helpful to health economists who determine funding for people presenting with long COVID.
I probably don't know enough as much as I should about what health economists need to input into their models, but my guess is probably what they need is something around the size of the problem, and the new data that came out from the Ministry of Health, I think, is really clear. They reckon probably about 185,000 people in New Zealand with long COVID at the moment.
Okay.
Probably what are the other things that people need? So that health economists might need, probably if you're looking at primary care, is the average number of visits. I mean, that is a big determinant of cost.
Mm.
Um, and then there's productivity losses. So things around the proportion of people who can't work. And so we've done some work on that, looking at how many people can't work, how many people have had to cut down their work, and together those two are probably about half of people with long COVID, and another quarter of people saying that they're still keeping up the same hours of work but are less productive. Um, so that's really interesting in itself that people acknowledge that, and yet
Mm.
are probably because of financial pressures having to continue going to work. But I'm really happy to engage with her and talk about you know what kind of evidence that we've got, because we're sitting on this big goldmine of data that could be
Right.
useful in an econometric model.
So the model that you've built, you focus on long COVID, but in theory, could you replicate it the same way back for chronic fatigue syndrome or other?
Absolutely. I mean, I think that but a lot of people who've looked at it have said, actually, there's nothing specific in here about long COVID. This is about chronic illness. There's a huge overlap with ME, without doubt. A lot of it, I think, could be used. There are a number of people who were in our group who didn't have symptoms of MECFS. They had symptoms of organ damage, which was very
Right.
specific to long COVID. And so we did try to be as inclusive as possible to the whole variety of presentations of long COVID that we had. Having said that, I think it'd be a really relatively straightforward change to make it ME specific. And I think it would be quite easy to make it chronic disease specific or relevant for all chronic diseases, because a lot of it is about recognizing that people have got this illness, require you know ongoing support, and that this isn't just about symptoms. But I
Mm.
guess probably what's the specific thing about ME and long COVID is the fluctuating symptoms, and that I think is one of the things that makes it really hard for health professionals to kind of know how to deal with, and that's why a lot of people liked that symptom map, that spiderweb diagram, which allows you to go in and without having to use a huge amount of energy to say, this is where I am at the moment, and this is where I was last week, and this is where I was a month ago,
Mm.
because those things do change. So yeah, I think that has quite a lot of potential as a resource itself.
Yeah. 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 For me personally, I find it hard to figure out the relationship between correlation and causation. Like, is it because I'm tired or is it because of my long COVID or and so I start second guessing myself and so trying to figure out, all right, should I be pushing harder at exercise to get through this or not? It's so topics like pacing and stuff are really, really hard for me to kind of wrap my head around as an ambitious
Yeah.
person.
No, it's really difficult. I would have had ME for I think about 14 years, and I would say it probably took me about 4 or 5 to figure out exactly what pacing meant for me.
Right.
Um, and I think it's about learning what tips you over into post-exertional malaise, so into a crash, and
Mm.
then dialing back. This is how I implement pacing. Then dialing it back. So if I can say walk to the first lamppost on the street one day, making sure that I can do that and um, not have a crash by doing it, say, once a day, and then saying, right, well, okay, so that worked. I'm not going to walk to the second lamppost. I'm only going to walk to the halfway between the first and second lamppost. So you don't
Yeah.
try to push it too quickly,
Yeah.
and are just really aware of what a crash means for you. And for me, it comes out in joint pain.
Yeah.
So, if I start getting joint pain, I think, right, something's gone wrong here. But that took a long time to figure out. And because everyone's so different, I think it is really hard to, give one answer to what does pacing mean. So I think it needs somebody. I think it would be really helpful for people to have someone to work with, to work out for they themselves what pacing means, what PEM looks like, and therefore what's safe to do and what should be avoided.
I did have one other question emailed in. I'm not too sure if you can answer this, but did you come across any advice on whether people with MECFS or long COVID ought to have flu, shingles, and/or COVID vaccinations? GPs don't seem to have an in-depth understanding of these illnesses, so they can't give any guidance.
We didn't collect information on that, so no, I don't. My understanding from, which is really anecdotal evidence and nothing more, is that it works so differently for different people. For some people, then having vaccinations well, without doubt, vaccinations work, and you don't want to get those illnesses. You don't want to get flu. You don't want to get shingles. But if you are somebody who is very reactive to vaccinations, it may be that it might trigger you to feel worse or trigger a crash. And so I'm quite hesitant to, I'm pro-vaccination. I know there are vaccine harms, but I truly believe that the harm that comes from vaccine preventable illnesses far outweigh the harm that comes from, or the likelihood of harm from vaccines. So, but that's the case on a population level, and that doesn't always apply to individuals. And that's really hard then for an individual to make a choice. So I think if you have ever had a bad reaction to a vaccine, then you might well think carefully about whether you want to have another vaccine or not. If you haven't had poor responses to vaccines in the past, my sense is it's probably safer to try getting a vaccine than not, because of the risk of getting COVID again or getting flu can be really, really horrible. But for an individual, no, I'm sorry, I don't have any specific advice beyond that. Yeah, as I said to Rose at the beginning, really happy to engage. Not only with you, Simon, but with anyone, and anyone who wants sort of more information about the resource or sort of further or any other discussions. I'm always happy to have. Fantastic. Please do get in touch if you or your wife would like to. That'd be great. Take care. Bye bye.